Hello everyone, I am Ketki Aute with the topic of antiarrhythmic drugs. Now let us understand the topics which we are going to cover in this video. These are the antiarrhythmic drugs, classification of antiarrhythmic drugs, class 1 antiarrhythmic drugs, subclass 1B and class 3 antiarrhythmic drugs. Right? Now let us begin by understanding the normal physiology of the heart. Heart generates its own impulses with the help of SC node. Now the impulses from the SC node transmitted to the atria, from atria to the AV node, right? From AV node, the impulses get transmitted to ventricle and whole of the heart musculature with the help of bundle of His and Purkinje fibers. Further, let's understand the cardiac action potential. Cardiac action potential is the membrane potential of the cardiac muscles, which signifies the electrical activity of the cell during the normal contraction and relaxation of the heart. The cardiac action potential has many phases, right? Phase 0, 1, 2, 3, 4. Phase 0 is known as the phase of rapid depolarization, which is mainly due to rapid influx of sodium through the open sodium channels. Now phase 1 is the phase of early fast repolarization, where there is a stoppage of inward sodium flow and a start of outward potassium flow from the cell. Now phase 2, it is a plateau phase. In this phase, the calcium ion enters the myocardial cell through voltage gated slow calcium channels, and there is potassium which moves out of the cell through the potassium channels. Now phase 3. Phase 3 is the phase of repolarization. In this phase, the calcium channel closes and there occurs only and only efflux of the potassium throughout the phase. Now phase 4, it is a phase of spontaneous depolarization, where the membrane potential returns back to its resting value. In this phase, inside the Purkinje fibers, there is a spontaneous depolarization. Now, here is the diagram which signifies the normal cardiac action potential, with phase 0 showing the depolarization, phase 1 which is a very short acting phase, then the plateau phase 2, then the phase of rapid repolarization phase 3, and then the phase 4. Now further, we have done with the normal physiology. Now let's understand what are arrhythmias. Arrhythmias are the disturbances in the normal cardiac rhythm of the heart. Either there is an abnormality in the site of origin of the impulse or its rate, regularity or conduction. The arrhythmias can be either bradyarrhythmia or tachyarrhythmia. The important types of cardiac arrhythmias which we know are extrasystoles, then paroxysmal supraventricular tachycardia, atrial flutter, ventricular fibrillation, AV block, etc. Arrhythmias mainly can result due to impulse generation problem. That is, either there is SC node generating impulse too fast or too slow, or there is problem with the impulse conduction. That is, impulses are not properly conducted throughout the conductive tissue of the heart. Now, by understanding the arrhythmias, the treatment for arrhythmia is the antiarrhythmic drugs. That antiarrhythmic drugs are the drugs which are used to prevent or treat the irregularities of the cardiac rhythm. Antiarrhythmic drugs, these act by blocking the myocardial sodium, potassium and calcium channels. Now the antiarrhythmic drugs are classified in majorly 4 types: class 1, class 2, class 3 and class 4. Now let us understand the major classification of antiarrhythmic drugs. Here there is class 1, class 2, class 3 and class 4. Right? So class 1 antiarrhythmic drug is the membrane stabilizing agent. Then class 2 are the anti-adrenergic agent, class 3 is the agents which widens the action potential, and class 4 are the calcium channel blockers. The class 1 antiarrhythmic drugs are further classified into 3 subclasses: class 1A, class 1B and class 1C, as you can see in this classification. Now, class 1 antiarrhythmic drugs are mainly the sodium channel blockers, right? Class 2 are the beta blockers, class 3 are majorly the potassium channel blockers, and class 4 are the drugs which act by blocking the calcium channels. Now, let us start with class 1 drugs. Class 1 antiarrhythmic drugs bind easily to activated or inactivated state of the sodium channel, but poorly to the resting state, right? They block more when activation and inactivation is fast. That is, they block more when they are present in the rapidly firing fibers. The primary action of class 1 antiarrhythmic drug is to limit the conductance of sodium across the cell membrane. Right? Therefore, they majorly act as a local anesthetic drugs. By blocking the sodium channels, there is a decrease in the slope of phase 0, which results in decrease in the amplitude of the action potential. As you can see in the given diagram, there is decrease. The diagram shows decrease in the amplitude of the action potential, which also results in the decrease of the velocity of the action potential, which gets transmitted through the heart. Therefore, the red dotted line shows the graph of the action of class 1 drugs which are given. Right, class 1 antiarrhythmic drugs are further classified into 3 classes, as we know, class 1A, B and C. So class 1A are the drugs which shows moderate decrease in the velocity of phase 0. Then class B, it shows a little decrease in the change in velocity of phase 0, and class C, there is a marked decrease in change in velocity of phase 0 by the class C, class 1 antiarrhythmic drugs. Now let's understand the subclass 1B antiarrhythmic drugs. The drugs of subclass 1B majorly blocks the sodium channels more in inactivated state than in open state. They do not depress the AV conduction or prolong the action potential duration, ERP and QT. Right? These drugs, the drugs of this subclass, include the lignocaine and mexiletine. Right? Let us understand lignocaine action. Lignocaine mostly acts as a local anesthetic, but also has an antiarrhythmic property, right? Lignocaine, let us understand the pharmacokinetics. That is, lignocaine is taken orally. It is not taken orally, as it is not effective because of its very extensive first pass metabolism. Therefore, it is commonly administered by the intravenous route. It is widely distributed in the body as it crosses the blood-brain barrier. It has a very short plasma half-life period of about 1 to 2 hours. Now, let us understand some of the adverse effect of lignocaine. Lignocaine, as it crosses the blood-brain barrier, therefore causes CNS-related adverse effect, that is drowsiness, nausea, blood vision, nystagmus, twitching and fits. The high doses can also cause cardiac depression and hypotension. Apart from this, there are various uses, which are, it is preferred in the ventricular arrhythmias, like it is used to suppress ventricular tachycardia and ventricular fibrillation. It is also used for emergency treatment of ventricular arrhythmias associated with myocardial infarction, digitalis toxicity and cardiac surgery. Right? It has no action on AV nodal conduction velocity. Hence, it does not intensify the AV block during the treatment of ventricular arrhythmias in the digitalis toxicity. Right? It is not useful in the atrial arrhythmias. That is, lignocaine, we do not use it in atrial arrhythmias, as atrial action potential are of very short duration. So, sodium channels are in inactivated state for a very brief period of time. Therefore, lignocaine is not used for the atrial arrhythmias. Now, further, let's understand about the class 3 antiarrhythmic drugs. Class 3 antiarrhythmic drugs, its major action of it is to prolong of the repolarization with widening of the action potential, and also ERP is also increased. The drugs which comes under its variety are that is imiodarone, sotalol, etc. Imiodarone, it is an iodine containing highly lipophilic long acting antiarrhythmic drug which has multiple actions like prolongation of action potential duration and QT interval. Right? It is mainly the sodium channel, potassium channel blockers, but at the same extent it also blocks the sodium, calcium and beta blockers at the same time. Right? Its uses are, it is very effective in ventricular and supraventricular arrhythmias that also involves PSVT, nodal and ventricular tachycardia, atrial fibrillation, etc. Right? Apart from propranolol, amiodarone is the only antiarrhythmic drug which is which in very long term has been found to reduce the sudden cardiac death. Therefore it is a very commonly used antiarrhythmic drugs. Right? Adverse effect, amiodarone also shows some adverse effect like fall in BP, bradycardia, myocardial depression, etc. It also shows photosensitization and sunburn, like skin pigmentation occurs. Corneal microdeposits occurs, which are very common with the long-term use of amiodarone. Then there is pulmonary alveolitis and fibrosis, which is seen, which is a very serious toxicity of the prolonged use of amiodarone. Then peripheral neuropathy. With this, we have come to an end of the topic discussion. Let us further continue with some of the MCQs. First question, the drug treatment of digitalis induced ventricular tachyarrhythmia is? The answer is lignocaine. As we have seen in lignocaine uses, it is used in the ventricular arrhythmia of the digitalis toxicity. Right? Next question is, a 62-year-old woman is being treated for chronic suppression of ventricular arrhythmias. After 1 week of therapy, she complains about feeling severe upset stomach and heartburn. Which antiarrhythmic drug is likely to cause this symptom? The answer of it is mexiletine. It is a subclass 1B antiarrhythmic drug with lignocaine. Its major adverse effect is the heartburn and upset stomach, right? Third question, the most serious adverse effect during amiodarone therapy, it is pulmonary fibrosis. Now moving with fourth, antiarrhythmic agents. How do antiarrhythmic agents work? So antiarrhythmic agents work by changing the electrical conduction of heart by targeting the ion channels, as antiarrhythmic drugs mainly blocks the ion channels, right? Which of the following, fifth question, which of the following drug is not used for cardiac arrhythmias? Digoxin is used, magnesium sulfate is used, and adenosine is also used. Therefore the answer is nifedipine. Thank you so much.